good number of people is already here, so I guess we'll just
Good
get
morning, Dr.
started.
Haryadi.
Good morning. Good morning. Okay. All right. So I'm gonna click share window. Whoops. Okay. Hold on 1 second. 1 second. I need to put it in a slideshow. All right. There you go. Share. There you go. Share. We don't need the system audio, right? All right, so just like usual, I always want to give some communication interpersonal skills lecture. Remember, we have to create this kind of balance, okay, the one competence. This part of the lecture actually exists in your USC prep course if you have completed it. So it is becomes kind of like a reminder for you. I'm gonna present it in a little bit a different way, but the idea is still the same. So last week, we talked about the power of your hands, right? We want to show your hands, open hands, and use our hand gesture more. So because that create trust, they create warmth, they create bond. Now we're gonna talk about the power of your words. Now everybody here knows that the words have very very strong power. But I want to show you this one interesting study by John Bark in 1996. I guess my guess is nobody ever heard about this study before. Anyone have ever heard about this study? No, right? Okay. All right, cool. All right. So the study is an experiment. It's like a social experiment. Participants were told they are doing a language test. They're gonna need to forming sentences from scrambled words. There are three groups of words. The first group is root words, like this one. And then if you try to unscramble them, that becomes interrupt. There you go. That's the game, right? And that one is bold, and this one is disturb. Okay, so that's the first group of words. The second groups of words are polite words. They're like this one means courteous, that one respect, that one yield. Okay. The last group of words is just neutral words. It doesn't really mean anything. Okay? Like this one, bench, that one, system, and last one, structure. So there are multiple words, they need to unscramble them, right? Of course, the participant doesn't know like they are scrambling. You are going to unscramble root words, or you're going to unscramble polite words. They don't know, right? They don't know. And then what happened is after the word has, the participants were asked to find the experimenter for more instructions. What do I need to do next, right? But they don't know that the teacher or the experimenter was pretending to be in a conversation with another person. The researchers then observed whether the participants would interrupt the conversation and how quickly. And very interesting, what happened here is if you unscramble root words, you're going to interrupt 60% of the time. If you unscramble neutral words, you're going to interrupt 40% of the time. And if you do the polite words, 20% of the time. So this shows that words have power. It has power to manipulate. I would say manipulate is kind of like negative words, but actually influence people to behave the way we kind of want it. And of course, the one that unscrambled root words will interrupt much faster than the neutral one, and the polite would actually interrupt slower, right? Okay. So the people who were primed to act rude did so, and the people who were primed to act polite act more respectful. So this part of the lecture is exists in the USC prep course, which is the Pygmalion effect. You can actually prime people. You can help. You can set up people to success, or you can set up people to fail by using your words. Okay, that's what I said. The words that you use, you can influence others people's behavior. Now, here's the thing. Once you know this information, you can use this information to do bad things. You can use it to do good things. But I believe the people here will use the information for good things, right? That means you're gonna use positive words. Now, Americans love that. Okay, they want you to be positive. And what's that mean? Well, one of the things that you want to do is use positive words. Right now, how we can apply it to improving our chance of matching in real life. Well, of course, one thing that come up into a lot of people's minds immediately would be during the interview, right? I teach this in the Match with One interview. Praveen is already in my Match with One interview course last year. This is some part of it that I teach. So, for example, a lot of people will do, tell me about yourself. Oh, my name is Dr. So-and-so. I'm from here. I went to this medical school. I work at this hospital, number of years, then I did this, and then and that. That's it. But if you change that, put some more emotion words in it, and you can help to prime yourself to success, right? And you can change it this way. Hi, my name is Dr. So and so. I'm very excited to be here. I just can't tell you how much this means to me. Well, first of all, I would like to share that I'm originally from this place, which is so beautiful and gorgeous town, right? Beautiful, gorgeous town. I graduated from one of the most prestigious universities, successfully land a job at a very busy tertiary care hospital. You see how you set yourself to say that you don't realize that these small words actually really meaningful. You kind of like again influence the way the program directors or whoever interviewing you to make you feel like they want to rank you higher. So that's one thing. Now, what about the USCE, right? Think about in your workplace. You're gonna do USCE. You're gonna meet a lot of new people doing the rotations, right? And you're looking to get the strong personalized letter of recommendations. You want them to do that. You want them to behave that way. So what you want to do is you want to think about what you want that other person to feel during and after they interact with you. Your words matters a lot. Put a lot of positive emotion words, tell them you're excited to be there, tell them that the patient's very interesting. You just try to prime yourself for success. Another thing that if you have done rotations with me, that I usually do when I refer patients, let's say patients I'm looking for the orthopedic doctor. Okay, I need to be referred to orthopedic. Oh, sure, I will refer you to Dr. Fleet, because I know Dr. Fleet. I met him before. He did great. He's very thorough, and all of my patients that did surgery with him, they're very, very happy. So you set the patient for success because now they have a strong confidence to Dr. Fleet. And then if the patient is nice, they're going to say the same thing. And people have been speaking highly of you. And guess what Dr. Fleet is going to do? He's going to be more thorough and take care of the patients much better. Right? That's how you can use your words to control how the other people behave and act toward other people. Again, you can use this for bad things, you can use for good things. I hope you all, and I believe actually all of these people here will use the information for good. All right, that's it. Yeah, just 10 minutes lecture. Now we move on to our morning report. I'm gonna stop sharing here and go here and then share here and here and share. All right, so we're gonna do morning report. Actually, I have people who kind of really line up to do the guest speaking in a different program, obviously. But I figure let's try to alternate, and then I'll get your feedback. Which one do you like? The alternate? You like the guest speaking more? Or whatever. We try to make it more balanced now. So this is going to be internal medicine morning report. And this is going to be the case. I don't think anyone has ever done morning report in the US before. Okay, so if you have gone to US prep course, I mentioned to you in module 4 that maybe a lot of people think morning report is like you reporting the patient that was admitted last night. It has nothing to do with that. Has nothing to do with that. Morning report is just presenting interesting case in the morning, and you do the exercise of the unravel patient case and such. So it has nothing to do with reporting patients. Well, sometimes is a morning report of night floats. Well, that happens, but not necessarily that way. All right. So I have a 74-year-old female that come to the internal medicine office, complain of I'm feeling so weak, I can't do anything without help for the last 3 months. So if the patient said this, what would be your approach? Anyone? I feel weak. I don't feel I can do anything.
Hi, Dr. Haryadi, if I may.
Hi. Yes. Rocking, right? Yeah. Go ahead.
So, considering her age and the symptom, I would first ask her whether how long has this been
Yep.
bothering you?
Uh-huh.
Because why are you, if it's for 3 months, then
3
why are
months.
you
Yeah.
here now? Is there anything acute that's happening?
Mm-hmm.
And based on that, I would see whether this is a systemic cause or it's something focal.
Yeah.
And
Yeah.
then I will progress to see if there are any comorbidities that are adding on to her,
Mm-hmm.
adding on to the disease burden. And then
Mm-hmm.
based on the reply, I would move ahead with my questions. I'm looking for things like that things that suggest of anemia or any
Okay, that's your
other
differential
uh,
anemia.
B12 B12 different deficiency or stuff like that, or if there's anything that lead to malignancy in
Mhm.
the last cause.
Okay. All right. So you're thinking of maybe systemic abnormalities using labs, anemia, vitamin B12, and you're thinking malignancy. Okay. All right. So those are some of your
The
basic
farthest.
differentials.
Yeah,
Yeah.
yeah.
Some of your basic differentials. Okay. Anyone has any other way to approach when somebody come? I feel so weak, can't do anything. I will also tell you the reason why he came. Actually, I will show you the story. But she has been on urgent care a couple of times because of other symptoms. So it's not like she wait 3 months, but it's gradual. Yeah, getting weaker and weaker. That's why it's like 3 months for her. But yeah, anyone else wants to try how you approach? What's gonna
Dr.
be your
Hayadi.
next question? Yeah, go ahead, Muskan. Yeah.
Okay, so I think just another aspect that I would like to add on to this is maybe like first validate her emotions. I mean,
Mm-hmm.
if she's been to urgent care multiple times, clearly she hasn't found answers, right?
Yeah.
So I would want to first start off by like being like, I understand this is bothering you. I understand that
Sure.
this has been weighing
Yes.
on your mind and
Yeah.
this has been causing a lot of pains. I like a lot of like emotional pain. I mean, like
Yeah.
I would validate her and I would prompt her to speak more. I would
Uh-huh.
prompt her to tell me all aspects from A to Z, like when did it start, what
Okay.
aspects does she feel like it affects
Mm-hmm.
her in. I would ask her how has it caused her to feel emotionally and physically, what changes, and
Mm-hmm.
also like I mean, um, I think Praveen, yeah, he added on to a lot of good points, but also like asking her along this, like also asking her that has there been any changes in your like environment or your life or in terms of
Mm-hmm.
like just like lifestyle changes, have there been any recent lifestyle changes? So apart from everything that Praveen did talk about, I would also add on to that as well to my
Okay.
approach in this patient. But yeah,
Okay.
that's
All
how
right.
I would take it.
So you provide approach on, of course, you value their emotions practically. But I guess my questions are, how are you gonna put differentials on when somebody have complained at weakness? What are the possible differential diagnosis? Let's make it more
I
specific.
would also want to rule out any inflammatory causes or
Mm-hmm.
finally at the end fibromyalgia which would be which would be a diagnosis of exclusion
Mm-hmm.
if everything else is ruled out. So those two would be something on my radar as well, along with
Okay.
everything that Praveen did speak
Yeah,
about.
inflammatory, anemia, B12, like malignancy, of course, down the line, right? Anyone else have one more, I guess, before we move on with the case? Uh, Anyone wants to try to give differentials? Yeah,
Yeah,
Deepika.
I'd like to try. So apart from what they said, I would
Wait,
I would also like to consider any underlying cardiac or respiratory pathology.
yes, right. Cardiac and respiratory actually kind of top on differentials, because the thing is, when Americans say, I just feel weak, I don't want to feel do anything, sometimes it's so vague, especially when they say fatigue or weak, sometimes they not like really pointed toward breathing. And actually, they actually mean it's a breathing problem. So good. Yes, cardiac and lung respiratory. Okay. Now let's move on with the case. Now, there are two ways if you go through like up to date about how to approach fatigue, or you use the open evidence. This is and then also when I think I learned from the Yale curriculum, they like to do a bucket list based on organ system. So it's like this, okay? Like cardio. Is it cardio? So CHF, CAD, maybe some arrhythmias, right? They can cause symptoms. Is it pulmonary, right? So cardio, lung, right? COPD, ILD, OSA. Is it GI stuff like celiac, for example? It is hematology, anemia, like Praveen said. Is this endocrine stuff, thyroid? Forget that, right? Or chronic diabetes that doesn't have that's uncontrolled, right? Vitamin D deficiency is very low in differentials. I usually do it for fun, but yeah. MSK, if it's weakness like autoimmune, inflammatory, rheumatoid arthritis, myositis, and all of that stuff. Neurological, right? So multiple sclerosis, right? Some weakness, stroke. Nephrology would be kidney failure, chronic viral infection, malignancy, like Pravin said, and psych. And then I think, has ever any one of you mentioned this last one? medications. Like medications, yeah. People can take some chronic medications. Like I've seen people who feel so tired, they're just taking too high dose of metoprolol. So you need to consider medications as well. Now you can use this list really, when somebody say they are feeling tired and fatigued, and you just, what you need to do is go through the list, and then you can eventually point it out with what are the most likely explanations. All right. Now, but the way I like to approach, so it's easier for me, is I like to think of, is it breathing? Is it muscle? Is it sleep? Because if sometimes people say I'm feeling tired, well, I just feel sleepy all the time. You have sleep apnea, bro. So is it sleep, or is it others, which is all the labs and the meds and etc. Okay, and psych is slowest in the differentials, just because we are internal medicine doctor, so we don't want to just attribute them. Oh yeah, I think it's because you're anxious, or you because you're depressed. Before we rule out medical costs, we as internal medicine doctor will have to rule out organic costs first. Dr. Friedman, my attending, when they do morning report, we mentioned psych differentials. That's the lowest. That's the lowest one we think of. It would be awful to have organic causes and we don't treat them, right? Now, what if we have ruled out everything? We have done maybe asked the questions, and we have done the labs and everything, and then everything is negative. Have you guys ever heard of this diagnosis, the chronic fatigue syndrome? Yeah, no one. Okay, so chronic fatigue syndrome becomes more common after COVID. People talk about like post-COVID-19 syndrome and the stuff, but basically it usually happen after some form of an infection, but it could be anything. It's a very, very, very weird disease. Another cool name for chronic fatigue syndrome is myalgic encephalomyelitis. Chronic myalgic encephalomyelitis. This is a diagnosis of exclusion, obviously. What I like, and I've diagnosed this a couple of times, and only primary care would dare to diagnose a chronic fatigue syndrome, because the other doctors are going to say, let's say you meet with endocrinologists, and they say fatigue. They're going to say, well, I don't think it's from the endocrine cause. Your thyroid is normal, your diabetes is well controlled, so I don't think that's the case. Talk to your primary. That's what's going to happen in US. Okay, so nobody will ever dare diagnose a chronic fatigue syndrome other than a primary care. So I diagnosed this a couple of times. The way I like to see the chronic fatigue syndrome is the post-exertional malaise. So when they do activities or exercise, usually you gain a little bit more energy. This one is you crash, like you crash so bad. That's the way the Americans like to say it. I really crash. I become so tired, can't do anything for 1 or 2 days, after you do exercise. And exercise could be like just a treadmill of half an hour, or maybe you do some walking with your dog and then you just crash. So those are kind of like the main hallmark that I like to use. And the other ones accompany them, like orthostatic intolerance, cognitive dysfunction, unrefreshing sleep. There is one more, and I think I don't put it. Okay. There is one more that I didn't mention here, and I didn't mention on the list of differentials, which I should, which is this one probably deconditioning. Deconditioning. Yeah. So if the patients, usually the condition will be kind of like a little bit obvious on the history, like you had a stroke or you got a really bad disease, you're in the hospital for months, right? 1 month, 2 months, because of all complications. After complications, you lie down on the bed, and depending on how good you are with physical therapy, you might not be able to do them. You become very, very weak now, very tired, and that's the conditioning. The way the story goes would be very different than myalgic encephalomyelitis. Usually for chronic fatigue syndrome, there is some incident. COVID-19 was one of them. If you're in New England, they like to say Lyme. They're gonna blame it to Lyme. Do I have Lyme disease? I feel so tired. Just maybe Deepika have seen some of those cases and mentioned that. All right. Now we know the bucket list, right? We have cardio, we have lung, we have all those. Okay. So I want to give it to the audience. How are you going to ask these patients if you want to investigate, is it a breathing problem? How are you going to ask the question? I'll give you an example.
Good morning, sir.
Oh, yeah, go ahead.
We
Go ahead.
might I have to ask them if they have a difficulty in breathing when they are lying down.
Yeah,
Uh,
good. Uh-huh.
and in during and when they are sleeping, we should ask them if they have intermittent episodes of breathlessness for which they get up and try to catch their breath.
Good.
And we could ask them, we could try to grade that level of breathlessness based on the NIHA classification.
Mhm.
Like, for example, we'll ask them on what degree of activity is your breathlessness usually severe? Like, is it like simple activity or something like walking up the stairs or something like that? So
Yeah,
that we can grade them based on the New York Heart Association
correct.
classification.
Okay, that's good. Yeah, you're asking for autopnea, and you're gonna ask, do you feel short of breath when you're lying down? So that's my line. You can, I mean, this will be recorded. You can copy my line. Do you feel short of breath when you're lying down? Right. Have you ever wake up in the middle of the night feeling short of breath? So that's for the paroxysmal nocturnal dyspnea. And then for overarching breathing, I like to ask, do you have a hard time catching your breath, or you feel winded? Those are the way I like to ask the question if it's breathing issue. Another thing, if it's pulmonary, usually has cough. Usually, do you have any cough? So if a cough is kind of suggestive, could be a pulmonary component in there. Like COPD has cough. ILD usually has cough. Right? For muscle, how are you gonna ask? If this were kind of like muscle weakness, how are you gonna ask that question? Yeah, anyone?
If this person
Yeah.
has the habits of lifting, do you find it difficult to lifting stuff that you lifted before? Or do you
Yes.
find difficult to handling stuff?
Yeah.
Do things fall off your hands? Something like
Yes. Yes, that's right. Are you having hard time to move your arms or legs? That's how I like to ask it. For
To
sleeping, oh yeah, go ahead, Muskan. Yeah.
just two more things. Like we can
Yep.
also ask them, have they been having trouble combing their hair, or are they
Yeah.
having any trouble getting out of a chair,
Yeah.
or like
Yeah.
those two things I would just add on as well.
Yes. Good. Yeah. So sleep. For sleep, I usually ask, you have trouble sleeping, or you feel sleepy during the day, like you feel like you need to take a nap. That's how I like to ask it. If that's the case, and I have caught sometimes, they feel fatigued and tired. Well, you feel like you need to take a nap, like you are pretty sleepy and you just can't just crash suddenly. And then they're gonna say yes. Oh, that means it's a sleeping problem. You have excessive daytime sleepiness, right? So then we can do a sleep study to check for sleep apnea and others. The other ones are, for example, like anemia. Of course, it's easy. You notice any bleeding? That's easy, right? Urinary class, okay. And then medications, you review what the medications they're taking. Now, psych is lowest in the differentials, but you can ask, is there, the way I like to ask it for anxiety and depression, because you feel anxious, feel depressions, we like to look for a real, is there any change in your life? Is there any major life events that happened recently? That's the way I like to ask it. Again, you can copy the way I usually ask the questions. Okay. All right. Now, we move on to the story. Okay, so this is the story. Hoping this is big enough, but I'm worried it's not. But I'm just gonna read it for you, and I need to highlight. Okay, so she said that she has generalized weakness in 3 months. Okay, she has cough, lingering cough. So she went to the urgent care about 3 weeks ago. That time the cough started a week before she went to the urgent care. You see, is urgent care. They like to use that. Now, in this history, I like to put a lot of acronyms, the common acronyms that the US use. So if you get used to it, it's a practice. She had no significant SOB. Get used to that. Shortness of breath. Okay, so CD9, shortness of breath. She just have cough. And then the urgent care diagnosed her with upper respiratory tract infection. URI is that. Okay. The chest X-ray showed no focal consolidation or pulmonary edema. There was rounded opacity in the right lower lung indeterminate. They said that could be lipo shadow. It could be pulmonary nodule. Okay, it's common to get X-ray and found some random nodules, of course. Okay. And then they said that, of course, radiology wants to protect themselves. They don't want to be held liable. So they say that just do CT scan if you think it's necessary. It's very classic. Okay. Now, and then she was diagnosed with upper respiratory tract infection from the urgent care. And she asked for antibiotics. For people who has read the common brand names, what's Augmentin?
Amoxiclav.
Amoxiclav, yeah, amoxicillin. Good. For 7 days, they asked that, and then the urgent care granted that. Okay, and then she was discharged that same day. She was not admitted. Then patient described she was unable to ambulate without assistance of her husband. This is new, progressively worse. She feels the right leg is slightly weaker than the left. There is no arm weakness. She does feel having a hard time sleeping, but this I have to put that she doesn't feel like sleepy. She spends most of days just sitting, no activity due to weakness. She has combination of anxiety and depression, so this is chronic actually, especially when she broke her hand and fall about 7 months prior. So she had cross fracture of shaft of right humerus. They did the ORIF. ORIF is open reduction, internal fixation. Okay, yeah. She is a painter. She loves to paint, but now she can't paint. Sorry, like a T. She cannot paint. Yeah, and so that's why she feels awful. She can't do the activity that she used to enjoy. Right now, she has been taking Valium and Lunesta since 3 months ago. What's Valium?
Diazepam.
Diazepam. What's Lunesta?
Esopiclam, I guess that's how you say
Ezopiclone.
it.
That's right.
Okay.
Yes. Yeah. So Valium is diazepam. Lunesta is ezopiclone. Okay. She realized it might cause her to become more fatigued, so she stopped it about 2 weeks prior she comes to the office. Okay. She has history of hypothyroidism. She followed endocrinology. The TSH was elevated a couple of weeks back and recommended to increase the dose to 112. However, patient felt that the pill make her more having acid reflux on that particular pill, and so she stopped that and she switched herself back to 100 microgram. Okay. No, review of system. So she has no chest pain. She has no real focal neurological symptoms like, Bell's palsy, seven nerve. She just feels weak. She does feel the right leg a little bit weaker than the left. But arms, she denies any weakness. She does have low appetite, nausea, but she doesn't vomit. She doesn't have diarrhea or constipation. She has no urinary symptoms, and she doesn't have any bleeding. Okay. She never smoked. She doesn't do alcohol. She doesn't use any other substance use. Family history: brother he said that has some form of bone cancer. Mother has ovarian and cervical cancer. Past medical history here again: hypothyroidism. She does have obesity. She has previous anxiety, depression. She has osteoporosis as well. She had that surgery 7 months prior. She had C-section, remote, left knee arthroscopy, remote. So she's taking Synthroid. Synthroid is levothyroxine, calcium, vitamin D, this and that, Lunesta, Valium, but she's not taking that for last 2 weeks. Right? So she stopped and stuff. And this one, a dose reduced to 100. Previously, it was 112. Okay. So on physical exam, the blood pressure is, and 1 month ago, 2 months ago, is pretty much unremarkable, right? The weight readings, I should put oh yeah, there you go. We have a BMI of 37. She has been overweight. I call it overweight. I used to become American now, but we like to say overweight. But she has been obese. She has been obese a long time. I know her for quite some time. She has been losing weight. You see, 5 pounds loss, 7 pounds loss. Okay. Physical exam, actually, there is nothing really significant. The heart, lung sounds are pretty much normal. There is no leg swelling. And there is some weakness of the leg. It does feel that the right leg is a little bit weaker than the left leg. The arm strength is pretty much fine. Okay. So, after you got all this story down, what are the differentials? So, real life is like this, I feel that, I have the, sleepy, I have a hard time sleepy. You feel anxious? Yeah, I feel sad. So, a little bit of everything. Yeah. But I want you to think like what are kind of like more on top of differentials. Do you think this is more respiratory stuff, cardio, lung? Do you feel this is more muscle stuff? Or maybe you can think of it muscle stuff, maybe sleeping, or maybe it's more of the medications, or is it more on the mood? What do you think? Anyone want to give opinion?
Can I get her saturation, how it was?
Oh, yeah. Sorry about that. Her saturation was normal. 94, 95%. Yeah, I remember.
I think I'm leaning more towards maybe medication related,
Medication related?
because
Uh,
she lowered her dosage for the thyroid supplement, right?
yeah, that's right.
Uh, I'm thinking maybe because of that, these like it could be related to this. I'm not sure, but I would like to keep it at the back of my mind.
Very logical. Yes, you see a change. You start to think like clinicians here, right? You notice there is a change in the levothyroxine. It was supposed to be 112, now 100. It could be contributing. Makes total sense. Okay. I guess one more.
I would also
And I think maybe
Sorry, if first.
psychosocial problems, because she said that she's been sitting all day after her fracture, and
Yeah,
plus she has prolonged inactivity and she's obese, so it could cause her muscle wasting and loss of activities.
logical. That's good. Yeah. So the conditioning is definitely part of our differential heal, because he's been sitting, not doing anything after the fracture, feeling awful, right? And then on top of that, she can't sleep, and she takes the Lunesta and diazepam combinations, and so medications. And Aditya, you want to say something? Sorry,
no,
Aditya first, I
I
guess.
just wanted to add on that you could ask her about her adherence to the antibiotic dose. So, like, to see if she completed the complete dose of the antibiotics to make sure her infection is cleared, and, like, of course, do a X-ray or CT scan again to verify. Yeah.
Oh yeah, so you're concerned of the infection. Here's the thing: the X-ray didn't show really anything. The augmentin is just she requested it. The urgent care doesn't actually want to give it to her, But she requested. She felt okay. Well, fine. We'll give 7 days. And so they give it 7 days of antibiotic. But the X-ray didn't show any signs of pneumonia. If this were an upper respiratory tract infection, then it should be recovered pretty much by now. It won't be leading toward her unable to get off the chair and then need assistance from her husband, right? Yeah. So yeah. So
If I
yeah.
can add
Mhm.
on, Doctor, I think since there was, okay, this is just I was also thinking why to also explore in the malignancy and like a paraneoplastic syndrome kind of picture,
Yeah.
because she does have chest X-ray did show an unspecified node, like an
Nodule.
unspecified
Yeah.
nodule, right?
Okay.
So I would want to do a repeat X-ray and maybe a CT scan if there's another nodule, and also to I thought of polymyositis,
Oh, okay.
because she's having trouble ambulating, she's had weight loss, and she needs her husband's help to move around. And she also fell and had a fracture. So that makes me think of she's weak, she's not able to get up. Made me think in that direction as well.
Makes total sense. Very good. Yeah. Yeah. So now you have mentioned what you guys want to do, right? So X-ray repeat. Of course, we're gonna do some labs, and then if you think polymyositis, we'll do CK, aldolase, right? ESR, CRP to see if there's any inflammation. TSH, right? You want to check the thyroid. How's the thyroid doing now? Okay, all right. So yeah, put CBC, CMP, ESR, CRP. I throw in vitamin B12, vitamin D for fun. TSH, CK, and an aldolase. So those are the basic ones. So give you my thought process. Pretty much agree with all the things that you said. I put medication deconditioning as the most likely one. And then I keep the thyroid and the other stuff as the least likely one. But I put that on the top. Of course, cancer is in the differentials because of family history, whatever. But we'll keep that in the back of our mind, of course. But yeah, I didn't mention, but she completed mammogram and colonoscopy. Sorry, I didn't put it here, but she compliant with that, and those are negative. Okay. All right. So let's see the labs. So this is TSH. Okay. This one is the most recent one on the top. So that's normal. Previously was 10.9, right? So that's why the endocrinology increased it to 112. Yeah. And previously, all of those are normal. And mind you, all of these was when she's taking 100 microgram. So only one time that it was off and a little bit over 10. And then after that, it came back to normal. Yeah. All right. So that's the TSH. Then we have a CMP. Okay. For the CMP, this one's okay, maybe okay. I like to say that for BUN and creatinine because it's very close to 1. Glucose high, calcium 12. And then we have low albumin and high globulin. The rest looks fine. Normal alk phos, normal that, normal liver enzymes. Okay. ESR and CRP. Vitamin B12 is 1,996. So it's very, very high actually. Okay. ESR is 57. CRP is very high at 220. Normally, what CRP is 10, right? So yeah, 3 digits. So that's high. The CK is low. Then we have the CBC or CBC. This one is the most recent one. Okay, white blood cells 17, hemoglobin 8.6, which is if you compare it to the year before, it came down, and that's the lowest one. We have some, of course, lower that. MCHC is lower. Platelets is 453. LDW high. And it's pretty much kind of like the summary. So we have normal TSH, we have high glucose, calcium, albumin, globulin, that, and high ESR, CRP, B12. Okay. So what you want to do? What do you think after you see the labs? How are you going to approach the next thing? Let me put that back because so you guys can see. Okay.
Since it's probably inflammatory, maybe you can start on some kind of steroids and see how it goes from there.
You're going to do steroids and see how it goes. So that's one thing, one approach. Okay. Anyone else? What's the next thing
Why
that you
don't we
want to
do
do?
a peripheral blood smear just to see the morphology of the cells, WBCs, and I mean, she has thrombocytosis and leukocytosis. So I just want to see, and also for the RBCs, like just to do a PBS maybe, just to see what's going on.
Okay.
Not sure
All right.
though.
I
Really
take
not
that. Okay. All right. So peripheral smear, right? Peripheral smear. And then the other one wants to do steroid. Okay. Anyone else?
Yeah, to echo with Muskan's thought, I was also thinking of something bone marrow malignancy, something in that direction. So yes, a peripheral smear, or possibly after the non-invasive ones, we can go for a bone marrow biopsy to see if there's anything in that direction. That's where I'm
What
thinking.
malignancy you guys are thinking?
I'm thinking that because of the higher WBC and platelet counts and the lesser hemoglobin, there is a possibility that there is no space occupying lesions in the bone marrow, and
So you're
therefore,
thinking leukemia?
yeah.
Okay. Yeah. Right.
Can we check PTH and was ALP normal? I'm not sure. I mean,
ALP
I
was
think
normal.
okay. So since she has hypercalcemia, why don't we check PTH as well?
Good idea. There you go.
I would
Because
like
if
to try.
PTH is low and calcium is high, then that definitely takes us in the malignancy.
Malignancy directions. Okay. A good idea. Yeah. PTH. Anything else?
I would like to try electrophoresis since the
Electrophoresis. Yes. There you go. So now you're thinking what? Multiple myeloma, right?
Yep.
Yeah. Patient has anemia. The patient have high calcium. The patient has low albumin and high globulin. Fits. Yes. And the anemia is new, like 10 dropped to 8. The creatinine I didn't show you, but it actually going up. So baseline is on 0.6, 0.7. So it definitely went up. So it fits. Yes. So immunofixations. Okay. All right. So so we have idea of flow cytometry, peripheral smear or flow cytometry. Leukemia, in my opinion, is kind of a little bit lower in differentials. The reason is because if you see here, okay, fair. You didn't see. So that information you didn't see. So I usually see the like the number percentage of lymphocytes and all those. And this one is more neutrophilic predominant and doesn't have like blasts or so that's why I think it's lower. But I was thinking this is multiple myeloma, right? So here, hold on. Okay. So I was thinking multiple myeloma because of the because of the pattern. But this is a quick review of the hypercalcemia. I got this one from Up to Date. Yeah. So when your patient has super high, of course you want to admit and give the treatment, all those. No, you refuse medication supplement, right? And then if hypercalcemia is confirmed, then you can do ionize and all those. Don't forget to check the albumin level. Her albumin is low, so actually the calcium is much higher than 12. It's worse, right? Now, so what's the PTH? If it's elevated, then it's a primary hyperparathyroidism. If it's mild to normal minimally, and then it could be primary, consider FHH. If it's low, normal, or low, then you do the non-PTH mediated, which you check PTH-RP, vitamin D, and 25 vitamin D. If it's elevated, then cancer more likely. If it's not, you do the 125. If yes, that means those lymphoma, sarcoidosis, is granulomatosis. If it's no, that means is 25. And if it's high, of course, the vitamin D. If not, you do the multiple myeloma workup. And if not, it's others. Now, if you do UWorld, they use this one, right? This one is much easier, actually. I like to use this. So for people who is doing the step 2 CK, I personally feel hypercalcemia is a free question. Because when you see a calcium, you just quickly see the PTH, and then you can make decision on what to do next based on that. They will provide that information for you. If urine calcium is high, that this, and then if they don't have that information, then you use the vignette to actually at least differentiate either that or this one, right? So for example, if the patient have very severe ESRD, then you know it was probably tertiary then, So it's a kind of like a given. If it's not that, then you just need to look all this information, and I'm pretty sure you will get to the answer very quickly as long as you remember the algorithm. So that's just a quick review on the hypercalcemia. Okay, so high differentials in this case would be a malignancy, and especially multiple myeloma because of the pattern. But however, the way I like to think is when I saw these labs is that, well, the high neutrophils and all those, patient could be septic. Who knows? She got a real bad infection now because the lab show up a day later, and she has cough. And it felt unlikely because it has been 3 months, but I need to make sure that she doesn't need to go to hospital now to get some antibiotic of some sort. So let the nurse to do the triage, making sure she has no high fever or hypotension now because that was the day before, right? Or altered mental status, or maybe she needs IV fluid. Well, she can eat still. She doesn't have active shortness of breath. She said that the symptoms has been the same the past 3 months, so making acute sepsis unlikely. So the additional labs at the ferritin, flow cytometry, right? LDH, PTH, PTH-RP. So this is the result. Right? PTH is low, PTH-RP is 14, free light chain, and that was high, iron low, TIBC low, transferrin low, ferritin's high, LDH 211. So that means this is what? Malignancy, right? But it's unlike that. I was thinking multiple myeloma, but this one suggestive acute inflammation pattern, and it's polyclonal, no monoclonal proteins. So this patient doesn't have multiple myeloma. She has other malignancy. She has a high PTH-RP. So what do you want to do next? You know the PTH-RP is high. Final step. Yeah.
I think we can maybe investigate the lung nodule again.
Yeah. So what study you want to do?
CT scan.
CT scan.
We can go
Chest
for
CT.
PET CT.
CT scan. Yes. CT scan chest. What other cancer makes PTH-RP?
Small cell lung carcinoma.
Renal cell
Okay.
carcinoma.
Renal cell carcinoma. Yeah. And I think squamous cell does make PTH-RP too. You guys can kind of review that. In this case, that's gonna change what we're gonna do. CT chest, abdomen, pelvis is what we like to start with, and then whatever what we found, then we can stage with PET scan, etc. If we found something. Okay. Yeah. So full body CT scan, chest and abdomen, pelvis, and this what show up. This is the CT scan, the chest. So what do you guys see? Well, I'm not radiologist, so so just see the obvious stuff for me, right? See that? Yeah. Thing over here too. She had a lot of nodules apparently. And then we do the CT scan of the abdomen. What do you guys see? What's the obvious one? No radiologists in the crowd. No? Yeah. Anything obvious for you guys? No?
Is that Mets?
It's yes, if you combine those two together. But this is the kidney, right? So what's this one? That should be the same level. Yeah.
So it's a renal.
Yeah. 16 centimeter mass. So primary most likely this, and they mets to this. So unfortunate case. Yeah. So what's the final steps? We what time is it? 7:48. Okay. So once you see this, and I think the right thing to do would be to see in person rather than, hey, you know what, you got cancer. I mean, that would be an awful thing to do. The thing is, in the US, they have the portal, so they can see the readings of the radiologists. So they kind of have an idea already. But I feel the right thing to do is see face to face, try to break bad news, and explain what we found and then what we need to do. Yeah. So pain, right? There's a lot of pain. Start having pain. So opiate, of course. Put care management referral. So if there's any need at home, she will need wheelchair. She will need all the support she has, tools, equipments at home. Him on IR for biopsy, PET scan, CT scan, head for staging because she can get the MRI. So what happened next is she got admitted to the hospital. She was altered. Calcium was high. The case would be too long if we talk about how to treat hypocalcemia in the hospital. So that's probably your homework. You can learn about how to treat hypercalcemia in the hospital. There's IV fluids that has to be given. And then we sometimes give Zometa, which is the zoledronic acid, right? There are a couple of choices, calcitonin, etc. You can learn about that and see when do we choose calcitonin, when do we choose reclass. And under the video, there'll be a lot of comments that you guys can put a comment on how we treat acute hypercalcemia in the hospital. Yeah. But yeah, it was too much. The tumor burden was too high, so she becomes comfort care and hospice, and she already passed away. So that's it. Okay. Any question?
Dr. Haryadi, so like in the workup of this patient, was there any way we could have like avoided doing the whole workup for the electrophoresis and the whole RBC workup? If we just did the CT scan and CBC directly, we could have gotten a hint and avoided that whole like.
It's very difficult if except you have a fortune teller ability. We need to have a reasons of why we need to do the test. The one that I feel like not needed was the vitamin B12, vitamin D. Those are not needed, actually. I would admit it to you. I'll just do that. But she gets a lot of workups, additional B12 and vitamin D, actually not really adding up to the cost. The one that is very, very expensive in the US is usually scans, imaging, like ultrasound, CT chest, MRI. Those are the expensive ones. The labs, they're okay. They're not that crazy. Usually insurance cover them quite well, 80-90%, and it's not gonna go much. There are some crazy tests out there, like the PCR bacterial stool tests. That's crazy. It could be 2,000, 3,000 bucks now. That you don't want to do. But regular labs like this, the cost is already high to begin with. So adding additional labs will not hurt. I usually try to second guess myself if I need to do scan. That is why I didn't order the X-ray right away or CT scan right away, because that is expensive. Once I know that I really need them, I order them. Makes sense? Okay. Yeah. Any other question? No? Yeah. Well, yeah, this unfortunate case, but I think it's a good learning point here to review. We learn about the generalized weakness, how to approach them, and labs that are reasonable to order, and then review of hypercalcemia. That's basically kind of like the goal of morning report. Usually, during morning report, we try to give 1 or 2, maximum 3 things of learning points. We don't want to give like too much. That's what they do in the U.S. doing morning report. Now, in the US, every morning you're gonna do these type of exercises. That's how you become smart, right? And there'll be a lot of interesting, way more interesting cases. Depends on which program that you go to. Tertiary care, you're gonna see like something like way more bizarre than this. But yeah, hopefully you guys learned today. Enjoy that. And that's it.